Welcome to Altea Talks, the brand new podcast series being brought to you by Altea, the unique provider of combined insurance and risk management solutions designed exclusively for the medical, allied health and care sectors. I'm going to be your host, Will Marshall, and I'll be joined in this series by some of the leading movers and shakers from across the sectors. My guests are going to include practitioners and professionals, regulators, clinical risk and governance specialists, and an array of legal experts who are going to help us get to the heart of the hottest topics affecting the UK's health and social care sectors today. So, if you're looking for frontline knowledge and expertise, if you want valued insights into these most dynamic, challenging and rewarding of sectors, then look no further because you're in the right place. Welcome again to Altea Talks. Hello and welcome to the latest edition of Altea Talks, our regular podcast series in which we discuss a number of the key issues of the day affecting the health and care sectors. I'm particularly delighted to be joined in this episode by Caroline White. Caroline has had and is continuing to have a long and very distinguished career, specialising in clinical governance, quality improvement and patient safety. Caroline has held an impressive array of senior management roles over the course of her career, both within the public sector and in the insurance industry. Notably, these include a stint as Executive Director for Integrated Governance and Chief Risk Officer at King's Hospital in London at the height of the COVID pandemic. Caroline now runs Candere Consulting, which specialises in providing organisational training and development to the healthcare sector, with a particular focus on governance, risk, compliance, safety and quality. Caroline, welcome to Altea Talks.
Thanks, Will. It's good to be here.
In today's podcast, we are going to be discussing the perennial challenge of patient safety. This is a topic that seems to be never-ending and continues to capture national headlines wherever it goes. Most recently, we saw the Parliamentary Health Service Ombudsman's Broken Trust report, which was an analysis of 22 complaint investigations that the PHSO had carried out over the preceding 3 years, all relating to avoidable deaths within the NHS. The report highlighted a number of recurrent clinical failings, as well as persistent failures to respond to patients and families in a compassionate way when they raised complaints. We don't have enough time today to go through every aspect of the report, but what I wanted to do, if it's okay with you, Caroline, is to focus on the compounded harm conclusions of the report, i.e., the way in which the pain and the harm that patients and their families had suffered due to a clinical incident or accident was then made worse by the way in which the organisation investigated and responded to that.
Yeah, that's good to go through. Thanks, Will.
So it seems to me that the starting point in looking at the PHSO's conclusions when they were talking about compounded harm was this perception that healthcare organisations were struggling to be open and honest, or to be perceived as being open and honest by patients and families when they felt that something had gone wrong. And obviously, we're now several years after the statutory duty of candour was introduced following the Francis report. And it would just be helpful, I think, Caroline, to get your views about that and about why it is so important to be entirely open and frank about things when they go wrong in the healthcare context, and why some organisations, at least according to the PHSO report, appear to be struggling with this.
So I think the duty of candour is something that we've been having, although that there's the statutory duty that's been more recent post the Francis. We've had the Being Open principles and the Being Open framework for a long time certainly in the NHS, but more broadly, they've been available within the health sector. So the NPSA, the National Patient Safety Agency, launched the Being Open framework and Being Open principles back in 2005. So we're almost 20 years down the line from when they were first published. And that really does do what we require it to do. It sets the scene on making sure that patients and families are at the centre of investigations and inquiries around what's happened with their care and the treatment, and when something's gone wrong. It gives us really clear guidance on how to handle the being open arrangements, and very much around making sure that we are open, honest and transparent. And I think the thing that's probably the biggest factor from a healthcare provider perspective is the capacity to be able to both carry out good investigations, robust, thorough investigations, and also to keep in touch with patients and families through the process when an incident has happened. And it may well be that we don't find out about an incident until somebody brings a complaint to the organisation. And that in itself is something that we need to look into and understand, as if it is indeed a complaint that's the first time that we hear about something. Certainly in my experience, the initial apology and the saying sorry when something happens, I think clinicians are good at and experienced at breaking bad news. That's something that they do in their regular work. I think that some of the challenges are around what happens after that initial conversation when something has gone wrong. We then get into a space where investigations are happening. We might not necessarily have an update to provide to somebody. And sometimes some of the organisations that are struggling with this are the ones that don't keep in touch and keep people up to date.
And this must be particularly challenging for the smaller organisations where you have people who are maybe wearing more than one hat and who are assigned to deal with these things, but also have a very busy day job as well.
I think that's right. I think that a lot of the smaller organisations, or certainly the organisations that aren't the big acute hospitals, have much smaller teams to support the processes around investigation and complaints handling and complaints management and keeping in touch. The Being Open framework made the recommendation that the person that ought to be having that conversation should be somebody who has a good relationship with the patient or family, and quite often that would be the lead clinician. But of course, we know that health services and the provision of care is something that's the capacity to be able to do that and just to provide the care, it is often stretched. So then when there's investigations that are happening, to be able to look into the matters and what has gone wrong, those take time. Obviously, best practice would be that the people that are investigating aren't those that are involved with the actual incident themselves. So we could be relying on a different part of an organisation to be conducting that review or investigation into what's happened. And so there's quite a lot of moving parts to making sure that patients and families are kept engaged, they're involved in the investigation, their perspectives are sought, they're updated on the lines of inquiry and where things are at, and just keeping in touch. So there's a lot to go into coordinating, but absolutely being open and honest and transparent and saying sorry and it being a meaningful apology really does make a difference in my experience. People want to know that there's a level of accountability and ownership of what's happened, but that people are taking it very seriously and looking into matters when it necessitates.
Yeah, it's interesting what you say there about the importance of the investigation process, because that was a further criticism in the broken trust investigation, where the report was particularly critical about the quality of investigations into adverse incidents. And the Ombudsman found, I'll quote, an ingrained defensiveness and lack of curiosity about the causes of harm, and found that a number of the investigations that it analysed had failed to provide a clear, evidence-based explanation in response to concerns that had been raised, and also didn't provide reasons for the conclusions and the decisions that were made in the investigation report. And that certainly resonated with some of my experience of reviewing these things. But of course, you had far greater exposure to them than I. And I just wondered whether that was also picking up on things that ring a bell with you as well.
Yes, it does. I've looked at and reviewed hundreds of complaints responses and serious incident investigations over the course of the last almost 20 years, probably a bit more than that. And I think the thing for me that in doing that, and that experience comes alongside having investigated matters myself, there are lots of factors that go into and impact the quality of the investigation, whether that be for a complaint or for a serious incident. Those are in the context of time and capacity when you've got competing priorities and demands, the skills that are involved in doing a thorough investigation, and making sure that the staff that are doing them have got the appropriate training, but also support to be able to deliver that investigation in a way that means that they aren't having to juggle a lot more and other responsibility as well. Oftentimes in organisations, the people that are the ones being asked to investigate a matter are also dealing with overseeing the provision of care and treatment and services, and those are very busy roles with competing priorities as well. And this is a really important piece of work, an investigation into something that's gone wrong. But if we're not giving the dedicated time and resource and support to be able to do that, then the quality of the investigation does suffer. And certainly one of my observations from those that I've reviewed is quite oftentimes the complaint response that's prepared to go out to the patient or their family member that's complaining on their behalf, or indeed a serious incident investigation report that's prepared. Often they will give a chronology of the events that have happened and then jump, and literally the report jumps to the conclusions without showing the analysis and the weighing up of the evidence and the process often of what has been involved in that investigation and what's been looked at. So the showing the workings out often is missing. And I think that in part can lead to where patients and families feel that something's being hidden, because it doesn't necessarily always show what has been looked into or indeed what hasn't. And so in the absence of that, even, I think when you compound that with delays and people not being in touch and a hesitancy in saying where things are at, I think all of those factors do impact patient and families' experiences and the reasons that they do move to the Ombudsman for help to get those answers, or indeed onto a claim.
So in your experience, where the investigation has been inadequate, there's an increased risk for the healthcare provider that the matter will escalate.
Yes, absolutely. And I think that there's more to it as well. That, of course, myself in a role where I have reviewed responses and have, when I read a response or an investigation, there are two questions in my mind. Why and so what? So if we're making a statement in a report or as a response, we need to understand that. So if I can't answer that in somebody that's reviewing them to sign them off, so to speak, so that they can be sent out or what have you, then I will go back with those inquiries to the investigator. And of course, that adds more time delay into the process. So I think fundamentally, if we get the investigations right from the outset and we make sure that we've got staff that have got dedicated time and resource to be able to fulfill a good quality investigation, making sure, of course, that families and patients are supported throughout the process and their perspectives are included within that process, then we're going to get a better quality of findings as well, which in turn should help us with learning where things are going wrong. So there's so many factors to that. Obviously, as we've talked about between the two of us ourselves, that we've got PSIRF coming in, the Patient Safety Incident Response Framework, which is the new NHS framework for investigating patient safety incidents, which of course will affect the independent sector.
Yeah, I was going to ask you about that, Caroline, because we know that's coming in for the NHS, but that's also, the intention is also that will be rolled out to the independent sector, initially in relation to independent sector providers who are caring for NHS patients. Is that right?
So PSIRF is going to be the approach that organisations, including the independent sector, are going to have to adopt. And the basic principles of investigation in PSIRF really aren't that different to what's been required of us previously, around making sure that we look at the system, that we are understanding various different human factors and component parts, and we look outside of just the isolated incident and go wider. I think the big difference for me is that we probably didn't, as in healthcare, do as was intended by the previous serious incident frameworks, and do thorough investigations looking at all of those factors. And a part of that was the time pressure that was put on with the requirement to do that investigation into a serious incident within 60 days. Obviously, there's some slight variations on that depending on the nature of what's happening in the context. But in the main, there was a time restriction, a deadline, if you will, to get things done. And in removing that, which is what PSIRF does, and says, actually, this is more about quality of investigation than quantity, because clearly we haven't in healthcare got what we expected to get, all of the learning, given all of the number of incidents that have been reported and investigated, that actually let's look at the quality of that investigation and do some very well so that we truly can get the learning. And so then we can make sure that makes improvements and therefore reduces the number of patient safety incidents that happen and the level of harm.
And I think that the Ombudsman's report was cautiously supportive and welcoming of that increased flexibility that PSIRF is going to allow organisations, but it also had some reservations, I think it's fair to say, that might open the door to some of the less scrupulous providers to use it as an excuse not to investigate matters which clearly would otherwise have previously been investigated and which ought to be investigated. Do you share that reservation, or are you more optimistic that PSIRF will drive the quality of investigations upwards as it is intended to do?
I can understand the Ombudsman pointing out in the Broken Trust report around the need to have an air of caution around those organisations which may choose not to investigate a certain type of incident when they have also potentially got a negative CQC inspection result, and there's other soft intelligence known within the area to essentially require the integrated care system to bear that in mind and to triangulate its intelligence and to assure themselves that organisations are investigating appropriately and the right matters. And I'm cautiously optimistic that if we do PSIRF well, alongside the other aspects of what I would call integrated governance and risk management, that if we get that all correct and do it well, then we will see the improvements in patient safety. But I think we've got to bear in mind that doing any of these things in isolation, I don't think is going to get us to where we need to be, because it goes beyond the quality of the investigation. It's about making sure that we use that information, that intelligence, the data, the facts, and what it is that these reports and investigations and complaints investigations, patient safety incident investigations are telling us, and factor that into our quality improvement, our risk management, our approach to those aspects as well. And so where, for example, a report, an investigation has reached conclusions and made recommendations and an action plan has been drawn up to attend to the recommendations, that we ensure and assure that those are both implemented and then have had the effect that we thought that they were going to. So that brings us back round to the governance side of auditing, for example, making sure that we're getting feedback from patients and families and the full circle to really have an impact. I think the thing for me, the biggest difference as an NHS or a healthcare sector, independent sector, whoever is looking at this, is that we get risk management better. Because that's, for me, was the hallelujah moment of the patient safety syllabus, which came out as part of the NHS patient safety strategy around training staff in order to have a better understanding around patient safety and risk management, was the recognition that in order to prevent incidents from happening, we have to be more proactive on risk management.
That's really interesting because, of course, one of the main conclusions from the Broken Trust paper was the finding that really there had been unsatisfactory learning responses to most of these incidents that had been investigated. And what the PHSO reported, which I think resonates certainly with my experience from handling litigation in the health sector, is that most complainants want assurances that something is being done to prevent the same mistakes from recurring and ensuring that others don't face the same issues in the future is either a very important factor or at least an important factor in their decision to complain. And so really the focus of the report to a large extent was on the way in which organizations are really missing an opportunity to use complaints, adverse incidents as an effective way of promoting learning within the organization and managing risk to prevent recurrence. And that's something that resonates certainly from my experience of seeing lots of claims. And I imagine it's something that you would share.
Absolutely. The complaints, responses, the investigations and the reports that are written frequently that come down to the same things that are the causes. And so I think we have to take steps to understand that better and to understand within healthcare, how are we going to invest our finite resources in order to make the improvements around patient safety. And if we get that right and invest appropriately, and that will need us to invest up front and to get us off of what I would call our hamster wheel of keeping on going round and round, because we've been talking about these things for the same things for certainly the last 30 years to my experience, that in order to sort of break that cycle, we've got to start dealing with things in a way that, yes, we understand it's going to take several years to really feel an impact, but to be very dedicated to making sure that we investigate well, that we give staff the confidence to speak up, we support staff in being open with patients and to do our duty of candour, and that we within our organisations help with the culture of openness and transparency in order to support that. And that we have to some way change to stop trying to simply just get these investigations completed so that we can move on to the next one. And that's really where the patient safety incident response framework, the PSIRF, that's the real shift. It's certainly from my experience and the training that I've had on the old frameworks and the training for PSIRF, the actual principles of investigation, the principles of being open are no different to what they were 15 plus years ago, 20 years ago. It's actually how do we go about doing it, and having dedicated time and resource and the ability to say, actually, no, the fundamental that we have to get right here is a quality investigation that makes sure that patients and families are engaged, kept up to date, involved in the process, and that we're open, honest and transparent so that we can do just what you said to prevent this from happening to somebody else in the future.
Yes, thank you. And I think another feature of the Broken Trust report was, which jumped out at me, was the importance that the Ombudsman attach to making a meaningful apology and to saying sorry, but saying sorry in a way that you mean it, and how important that can be in terms of gaining the trust of the patient or the patient's relatives, but also in providing the patient with that assurance that there is someone who is accountable. It's not the same as being liable or at fault, but who is accountable. Is that something that you've seen across your experience of working in this field?
Absolutely. I would say that accountability and making sure that it's made really clear around that accountability. And that goes for both the patients and families where they've raised a complaint or there's been an incident and something's gone wrong, but also internally for the staff working within an organisation as well, and being really clear as to whose role it is to do whatever aspect it is as part of the investigation process, the duty of candour, the being open, but going further into risk management, into audit, into actually understanding that learning and implementing actions. And so I think we've got to get far better at making it really clear why we're doing something when, of course, we know that services are stretched. We know that there's finite resource available. And when certainly in the NHS, we know that there's an awful lot of pressure to deal with some of the fallout from the COVID pandemic, but also just even for the independent sector as well. The pipeline of staff to come through to fill our roles is stretched. And so we really need to make sure that we are making it very, very clear as to why we're doing this. But we've got to do it now. This isn't something that we can put off or rush to the next fire to put out and take all of our resource in that direction and not focus on this, because otherwise we're going to be here in another, or maybe not us here in another 30 years talking about it. But certainly I can foresee if we don't make those changes, inquiries and investigations on a national scale coming up with the same things.
Yeah, I mean, that is just to sort of bring it full circle. I mean, what we've been talking about, what the Broken Trust paper talks about, it's nothing new. It's a failure to be open and honest, criticisms of the quality of investigations, not responding to complaints effectively, the importance of making a genuine apology, and ensuring that learning is promoted and encouraged so that we're able to prevent the same mistakes from happening again. And certainly that's something that you've been familiar with for a longer period than I have, but for everyone involved in this space, we're quite a long way on now from the Francis report and the subsequent inquiries. And I just think to finish up, really just to ask you your view as to why is it that this is the problem that simply refuses to go away? Why do you think we're struggling to the extent that is identified in this report in implementing on the front line what is so familiar, at least in theory, across the sector?
I think that's the question, isn't it? Why is it so difficult? I think it's very complex. I think there's lots of things that come into that. I think culturally we are dealing with a lot of different parties, for want of a better description, involved with it, and where there's a lot of complexity and a lot of different players. I think the Ombudsman's report talks around the number of regulators and those involved from an external perspective to organisations involved with the patient safety agenda. I think that's a factor. I think so having some clarity of priorities and responsibilities and accountabilities, I think it would be very helpful. So I would agree with the Ombudsman in that space. I think internally within healthcare organisations, the culture within that organisation makes a big difference as to how well they deal with this whole arrangement around openness, transparency, speaking up, around being open, and in particular around governance and risk management and organisational learning and quality improvement. And I think if we can get better both in setting the tone from the top, be that internally or externally, around what's expected, and that this isn't about blame, this is about improving patient safety so that less harm happens ultimately, then if we get into that space, then we can make a difference and change how things have been. But unfortunately, there's a long way to go. But if individual organisations, be they small independent providers or big NHS providers, focus on getting it right for them, and then their wider system that they're working in brings together the learnings and that same ethos of actually understanding this for a wider population, then things will change. But it will be slow, but we have to start now.
Yeah, thank you. I mean, it's fascinating, and we could talk about these things all day. My sort of parting comment would be that it's so interesting the way you tie it back to patient safety and getting it right at the outset, because this is the same principles really that apply to risk management with regards to legal claims. I've found over the course of my career that it's making sure that you respond to that complaint properly. It's making sure that you carry out an investigation that is evidence-based and covers all of the ground. And then it's learning from those things that have gone wrong. Quite often it's too late to learn from a claim because it happened a long time ago. If you've got a complaint, that's the data that you have that is really relevant, really contemporaneous, and really rich learning opportunity. And I think that that's certainly something that will help organizations prevent harm to themselves, financial and reputational harm from claims, as well as the harm to patients.
I agree.
Thank you very much, Caroline. It's been a pleasure, as always, to talk to you, and very illuminating. And I'm very grateful to you for taking the time to join us on this podcast.
Been my pleasure, Will. Thank you.
Thank you for tuning in. I hope you enjoyed today's episode of Altair Talks. If you did, please don't forget to subscribe or leave a like or a review on whatever platform you're listening on, as this helps spread the word. If you have any questions or comments or topics you'd like us to explore in future episodes, please do contact us, as we'd love to hear from you. You can find us on LinkedIn or visit our website at www.altairinsurance.com. Stay tuned for more episodes, and until next time, take care of yourselves. The information contained in this podcast is not intended to represent a complete analysis of the topics presented and is provided for information purposes only for practitioners in the UK. It's not intended as legal advice, and no responsibility can be accepted by Altair Insurance or by Candere Consulting for any reliance placed upon it. Independent legal advice should always be obtained before applying any information to particular circumstances.